5, 4, 3, 2, 1. We are live now.
Good evening and warm welcome to the 39th session of Pediatric Orthopedic Active Learning Session. I am Dr. Dhiren Ganjwala, the coordinator for this session. The aim of this session is to invite eminent experts of pediatric orthopedic so that we can learn from them firsthand. The topic for today's session is management principles of neuromuscular foot problems. We all know that foot is affected in cerebral palsy, spina bifida, hereditary sensory motor neuropathy, muscular dystrophy, arthrogryposis, and lot many other conditions. The management principles differed widely. And what our expert for the today's session, Dr. Howard, is going to explain is like how these principles are different as well as similar for different neuromuscular conditions. Before I hand over to Dr. Howard, let me introduce him. Already we invited him before a few months to speak on the management of cerebral palsy hip problems. So we all know him, but still I would like to tell something about him. Dr. Howard practices at Nemours Children's Hospital, that's Alfred DuPont campus. He completed his medical training in Canada, and then he got trained at Royal Children's Hospital, Melbourne with Kirk Graham and Paulo Salber, followed by a fellowship in pediatric spine surgery at Starship Children's Hospital, Auckland, New Zealand. Dr. Howard also obtained training from Professor Gans about hip preservation. He has also written a wonderful book. I recommend all of you should read that. That's the Pediatric and Adolescent Hip Problems. In addition to his medical training, Dr. Howard also holds a bachelor degree in electrical engineer. So he's a versatile personality, not only orthopedics, but he's also expert of engineering principle. So with that brief introduction, I now invite Professor Howard to speak on today's topic, that's the management principles of neuromuscular foot problems. Over to you, Dr. Howard. Thank you.
Thank you so much for that introduction. I don't know if I deserve all those accolades, but I appreciate you, Dr. Ganjwala. Hopefully we'll get something good out of today's talk. And if you have some questions, I believe we'll be able to have them in the chat, I think. Is that right, Dr. Ganjwala? Okay.
Yeah, that's perfect.
I'm going to just share my screen. There we go. And hopefully we can all see that.
Yes, yep.
Okay. So without further ado, let's get into the talk. What I really wanted to focus on was, as was said, the principles related and also some pearls. So some technical pearls about how to do some operations and those sorts of things, but mostly on the principles of when, how you look at the kids with neuromuscular problems, what's similar, what are the differences, when should you apply different techniques or indications for intervention. And what I'm going to look at, I'm going to look at three diagnoses here today. So cerebral palsy, muscular dystrophies, and spina bifida. These are three neuromuscular conditions that have different etiologies. CP from the brain, the muscular dystrophy is obviously from the muscle, and spina bifida more from the spinal cord. But they do lead to similar presentations with common foot problems between them all, meaning equinus, most problem, talipes, equinovarus, so like a club foot, spastic equinovarus, and a calcaneus or excessive dorsiflexion due to plantar flexion insufficiency mainly. But I'm not going to talk about planovalgus and cavavarus. These are two talks on their own. So certainly we wanted to go there later. I can certainly do that as well as we discuss. So you can let Dr. Dhiren know. So let's talk about equinus or toe walking first. It's common to most neuromuscular diagnoses, whether it be CP or Charcot-Marie-Tooth or otherwise. And that tight calf can be very important, particularly in diagnoses which are typified by muscle weakness. So things like muscular dystrophies, where you've got a weak soleus complex, or a kid that's had has a crouching type pattern of gait. If you release that muscle further, you can really cause problems with their walking ability. That plantar flexion knee extension couple can make up for things like quadriceps weakness in a kid with Duchenne muscular dystrophy, for example. So you have to be very careful about how you treat those. And treating equinus is probably the most poorly treated deformity. It has an easy solution in a tendo-Achilles lengthening, which can often be done percutaneously. But the non-selective weakening of both the gastrocnemius and the soleus can really push you into a higher risk of crouch gait. And we'll talk a bit about that in a minute. It's the gastrocnemius, which is usually the problem, and the soleus is often not contracted except for in special circumstances. So the TAL can certainly lengthen the gastroc, but it also can lengthen a muscle that's not a problem, the soleus. When we think about contractures or shortening the muscle in a spastic condition, we think about them as being dynamic or spastic. So you see here is one of my previous fellows, Chuck Wenderenra, and you see he's got a spastic catch there with forced dorsiflexion. And then as he extends the knee, you can see that actually there's a static contracture there of his gastrocnemius. That means he has a short muscle. But the soleus, which he's testing right now, is not short, but it does have spasticity. So we need to differentiate between the dynamic and the static. And dynamic contractures need spasticity management and plus or minus casting and not surgery. So that's why it's important to understand that. To identify between the gastrocnemius and the soleus, we use the silver scale test. With the knee flexed, the soleus is tested, and with the knee extended, the gastroc is tested, since the gastroc crosses the knee and the ankle. You have to be careful to keep that hind foot in a neutral position, especially in someone with flat foot, because you can get your dorsiflexion, not through the ankle joint, but you can get it through the midfoot and fool yourself into thinking you actually have no contracture when you actually do, if you've done the test correctly. When I think about kids who can walk, and with respect to what the foot means for kids that walk, no matter what their diagnosis, I think about the prerequisites of normal gait that was put forward by Jackie Perry and Jim Gage. And particularly the first three here: stability in stance. So you need a good stable platform for the foot so that you can keep yourself stable, keep that plantar flexion knee extension couple in front of the knee. You need to be able to clear the foot during swing. So if you have things like equinus or a drop foot, then that can impede your forward progression of the limb during the swing phase. And you also need to pre-position the foot during that swing phase to get it ready for initial contact. And ideally, we want that initial contact at the heel, not at the toe. So keep those in mind as we go forward with this talk. When I think about stability and stance, I think about physics. I think about biomechanics. And Dr. Ganjwala told you that I'm an engineer, and I will never stop being an engineer. I constantly think about engineering principles when I think about how I treat these kids. But the most basic thing is a force and a lever, which causes a moment. So the fulcrum typically being like a joint, like the ankle, and the force being the ground reaction force on the foot. And depending on how long that lever arm is, depends on how that force acts on the body, the kind of torque it can generate. So it's very important. For example, you can see here on the side, the second rocker here, where that ground reaction force in red is well in front of the knee. And that pushes the knee back into a stable extension, which allows you to turn the quadriceps off. So that kids who have weakness in the quadriceps, they don't need to worry about that. They can augment their weakness just by having a good plantar flexion knee extension couple, meaning a good lever arm of the foot for which the ground reaction force can act on. Hopefully that makes some sense. And it's all about Newton's third law. So when this patient, for example, hits the ground, you can see that ground reaction force is initially behind the knee. And as they go forward, the soleus causes that ground reaction force to go in front of the knee. And so if you have a poor soleus, then that ground reaction force cannot be maintained in front of the knee, and your knee needs to bend, and then your quadriceps needs to act, and then you're in trouble, particularly if you are weak, because you can't keep yourself up. A little bit about the gait cycle. 60% of the gait cycle we are standing on our foot. So you see initial contact to the loading response is your first ankle rocker. Then your second ankle rocker is when your tibial shank goes dorsiflexes over the planted foot. And this is where a weak soleus can really exaggerate that ankle rocker and can cause problems. And then the third one, which is modulated by the gastrocnemius, that strong gastrocnemius just really propels that foot into swing phase. That's where the gastroc comes into play. And so that's important. But it's also important that you're able to clear the foot during swing. So you've got initial swing where you got your push off, then your mid swing where you've got a dorsiflexed ankle and getting ready for initial contact at terminal swing to get that heel strike. And this is where your limb is advanced. And you can think of that limb as a pendulum where you've got accelerated and deceleration of that swinging limb, which controls your cadence. Here's in a tiny bit more detail, your first rocker. You can see that red ground reaction force behind the knee, causing a little bit of flexion. Where you get a loading response, a little bit of flexion. You're accepting weight. You're accepting that impact, and then that ground reaction force goes right in front of the ankle, and then as you go further, it goes right to the toes. And so if you've got a good soleus and a good gastroc, then you're going to have a good lever arm for push off into swing. And here we are just getting ready for pre-swing. You can see that's the point where that ground reaction force goes behind the knee, which helps your knee to flex, which is important for foot clearance. So it's not only about having good dorsiflexion during swing phase for foot clearance, you also need knee flexion. So you have to be thinking about the whole limb when you're considering the prerequisites of gait and how you treat the foot. Here you are mid-swing, you can see that tibialis anterior activating to keep that foot in dorsiflexion so you don't catch your foot on the ground from a dropped foot. And then as terminal swing, the hamstrings start to decelerate that swinging limb. And again, your tibant is still firing in green there to keep that ankle in dorsiflexion to allow for that heel strike. But what happens if you do a non-selective lengthening of that soleus? What happens to that ground reaction force? Here's a kid that has diplegia, who had a tendo-Achilles lengthening. You can see that ground reaction force well behind the knee. And that patient is acting in crouch. If I could show you the moments that are generated at the quadriceps, you will see that they're very abnormal and activating that big quadricep muscle all through the gait cycle, very energy expensive. And that over time, that's not sustainable for most children with neuromuscular disease. So you want to avoid this and really try and not lengthen the soleus unless you absolutely have to. The soleus is so important. Here's a child here you can see on the right-hand side who it was a 12-year-old spastic diplegia. He had a very simple bilateral Hoke tendo-Achilles lengthening, percutaneous lengthening at age 4. He was insignificant equinus there, but he could walk around with his gait trainer until about age 10. After which that simple surgery at 4 caught up to him, went into progressive crouch, and now he's unable to walk even with assistance. And you see his dad's getting older and it's becoming more of a problem. So this little percutaneous non-selective lengthening of both the gastroc and the soleus is not so innocent. It's easy and it's done a lot, but you need to be smarter than that and be more selective in how you treat equinus in neuromuscular conditions. Here's another example where that lever arm is too effective. So here's a kid who has equinus here on this that left side that you're seeing first. That's a normal progression of their ground reaction force. But look here, he's in equinus on the other side, the ground reaction force way at the toes, way in front of the knee, and that overactive plantar flexion knee extension couple causes that hyperextension at the knee. So you also don't want that. That's also not something that's efficient. And also there's issues with foot clearance. So a calf lengthening in these cases can improve the gait prerequisites. But just like any medicine, and I heard you mention Paulo Selber there earlier, Dr. Gondwala, and certainly I learned this from him and Kirk Graham about the concept of giving the right dose of surgery. So here is one of Kerr's cartoons, which he let me use with his permission, to determine the zones of lengthening of the calf. Zone 3 being that tendon Achilles lengthening, which is very high dose. Zone 2 being more commonly where we work, which would be release of the fascia of the soleus and the gastrocnemius tendon, and that may be okay for somebody with hemiplegic CP or someone who's non-ambulatory who you're trying to get into an AFO. But you have to be careful in ambulatory kids. Mostly we want to work in zone 1, where you're just releasing the tendon of the gastrocnemius and leaving that soleus intact. So the lower the zone, the lower the dose. So think about dosing when you are doing these type of surgeries. So this is what you want to be doing most of the time. A strayer, gastrocnemius only lengthening. But when you think about equinus, it's pretty rare actually on its own. Here's a kid this is one of the few kids I could find that had, you would say, well, he's not really pure equinus, but is mostly equinus here. But this is kind of a rare event. So when you have pure equinus, you need to think, is there anything else upstream that I need to deal with? And the options for treatment here for this kid at his age is around 6, I believe, 5 or 6, will be casting plus or minus botulinum toxin, but that's a whole other talk. You have to be very careful with that as well. And it doesn't reduce your risk of getting contractures or orthopedic surgery. But surgery is another option. With something like spasticity management, you can, a lot of people use botulinum toxin, and perhaps that has a role in some kids. Here's a prospective cohort, but from Melbourne, which, big users of botulinum toxin, and indeed that's where I started using it. But they're not big users too much these days. This is a prospective cohort where they put botulinum toxin into the calf, and they looked at those patients over time. And although they found improvements in ankle dorsiflexion, now these are kids with no surgery, just Botox. Over time, a lot of these kids went into crouching gait. So that non-selective weakening of the soleus had them go into crouch even without surgery. So you have to be very careful about even things like botulinum toxin. In the operating room, here's a kid. If you look at them flexed, they've got a soleus contracture here too. This kid has hemiplegia, and when the knee is extended, they still have plantar flexion. So in this case, we did do a non-selective lengthening of both the soleus and the gastroc. You can see where we did it there at the musculotendinous junction, and this was a zone 2 release and called a Volpius. And this was not 3 in this case, but so if you need to address both the gastroc and soleus, I would suggest going through zone 2 rather than zone 1 for ambulatory kids. But the exception, I suppose, to the rule is a hemiplegic. And my trainees will often hear me say, hemis don't crouch. They've got a fairly normal, not 100% normal, but fairly normal, less affected side that can keep them up. So a tendon Achilles Z lengthening, which is non-selective, is probably fine in hemiplegia. Although I don't do it in hemiplegia too much either, because I think the strength decrease is pretty high. But in those cases, at least both the gastrocnemius and the soleus is tight. So if you have a lack of dorsiflexion of less than 20 degrees, the Volpius can be very effective and probably have you better post-op recovery of strength. And more severe contractures you can treat with a tendon Achilles lengthening. I think that's perfectly fine. But when you think about toe walking, it's not all about just having the heel up. So here's Jill Rada's classification of sagittal gait patterns in spastic diplegia, for example, and CP. And you see group 1 and 2 have true equinus. So that ankle is truly in plantar flexion. But there's another group 3, where if you look at these kids with a gait analysis, you'll see that ankle is at a 90-degree angle. And the only reason the heel's off the ground is because they've got flexion at the knee and hip. So the treatment is not to do a tendon Achilles lengthening. You do that in this kid, and next thing, you'll be moving into group 4, which is crouch gait. So you've lengthened the muscle that wasn't tight. You weakened it, and now it's very difficult to come back from that after that's done. So you have to be careful about the kid with apparent equinus. And just because their heel's off the ground doesn't mean that calf is tight. Let's talk about Duchenne muscular dystrophy for a second, and equinus and a muscular dystrophy. Here's a child who is, I believe he's 7 years old. Was diagnosed with Duchenne about age 3 when he was having trouble climbing up on ladders and things like that at the playground. And you can see this kid, if you can see it well, hopefully you can see it well. He's got some calf pseudohypertrophy there. His calves are big, and he's got early heel rise. His heel doesn't completely touch the ground, but at this point, he's doing fine. He's not having any problem with his walking pattern. He does have a contracture. If you measure him, he's got about -10 to -15 degrees of plantar flexion. But if you go ahead and release that and just lengthen that muscle because it's tight, you will adversely affect that plantar flexion, knee extension couple, and that kid will stop walking because they won't be able to keep themselves up. They need that little bit of equinus to put the ground reaction force in front of the knee, push the knee back into stable extension so their quadriceps can turn off, because it's too weak to hold them. That quadriceps is too weak to hold him up. He needs that tight calf. So you have to be very, very careful with that. If you do get to the point where that equinus is so bad that the kid is way up on the toes, their balance can be affected in those cases, and they'll fall and they'll sometimes have fractures. And then they stop walking because of fear. That's the kid that occasionally you can prolong their walking by another year to a year and a half by doing a well-dosed calf lengthening typically in zone 2. But you have to be very careful, and you just want to get them to about -5 degrees of plantar flexion. You don't want to get them into dorsiflexion at all, or else they'll just go into crouch and stop walking. So that's just a note of caution there. Let's talk about tendon transfers in neuromuscular disorders. In neuromuscular conditions, there's 2 ways you can transfer a tendon. The first thing is you can transfer a complete tendon, or you can split it in half and transfer half the tendon. And where you do those different techniques, it depends on the diagnosis. In general, though, the principles of tendon transfer still stand. To transfer a tendon, you need to have the adequate range of motion present, or you need to obtain it by lengthening other muscles. For example, if you have a dropped foot, you need and equinus, you need to deal with the equinus first before you transfer that tendon. That makes some sense. You need to have a strong muscle for transfer. If you only have a 3 out of 5 muscle, there's no point in transferring that muscle because it'll be a 2 by the time you transfer it and won't do anything. You need a 5 or 4 plus really to have a good active transfer that can help prevent recurrence and improve function. And you need a supple deformity. It needs to be flexible. If it's a rigid deformity, then also your tendon transfer is not going to work because your joint won't have the excursion you need. You also need to consider the diagnosis. If you do a complete transfer, like there on the top, you can see the top picture on the right is a child who's having a complete transfer of the tibialis posterior through the interosseous membrane to the dorsum of the foot. If you did that in a kid with spastic CP, you're very likely to get an overcorrection into that abduction of the foot and dorsiflexion, which can often be a worse deformity than you started with. So in those cases, when you have spasticity, and it's easy to remember because you got SP for split tendon transfer, SP for spasticity. Those are the ones that you do a split transfer. You don't want to transfer the whole spastic muscle. You need to have balance, and I'll show you an example of that in a minute. But if you have non-spastic disorders like neuropathies such as Charcot-Marie Tooth or muscular dystrophy such as Duchenne, then a complete transfer is what you need to do. You need all of that power to help augment what's missing in the patient. Here's a child with Emery-Dreifuss muscular dystrophy. These kids stay ambulatory for a lot of their life. They have problems mostly related to perineal dysfunction, so they get equinovarus feet. This child also has a tight gastrocnemius and soleus. So here's her picture. Just look at the right side. You can see she's in equinus. Sorry, it's kind of small. She also has inversion of that hind foot. She has some trouble with foot clearance. She's got to do a little bit of steppage. She's got a bit of a drop foot. So you need to do a strength assessment for her to see, well, what kind of, she's weak in her dorsiflexors and everters, but what do we have to transfer that's strong, that can augment that? So in her case, she has a strong tibialis posterior and a contracted calf muscle. So she had that strong tibialis posterior were released from the navicular and delivered it into a more proximal wound. This is medially at the just above the medial malleolus, about 4 finger breadths. Release that tendon, and then we transfer it behind the knee. You can see a little hole there. I don't know if you can see my cursor or not, but you could transfer it behind the ankle, behind the tibia, and make a hole through the interosseous membrane and deliver that to the dorsum of the foot. And then you basically drill down through your lateral cuneiform, and I usually use a button to tie it over at the plantar surface of the foot. So you completely transfer that tendon to the lateral cuneiform, which, unfortunately this video didn't work, but you can see here on that right side, she's got a more neutral foot. Her tripod has been restored, and she no longer has drop foot. She's got a good augmentation of her dorsiflexion during swing phase. What about non-ambulators? So, I talked about Duchenne muscular dystrophy as in the ambulatory stage, I'd be very careful about lengthening the calf muscle, but it does have a role in some cases. But in kids who are non-ambulatory, they often develop this equina varus deformity, which becomes quite stiff over time. This is really driven by the preserved strength of the tibialis posterior. And this foot deformity is initially flexible. And this is kind of the time to start thinking about things. When it becomes very rigid, when the kids are, older, 18, 19 or whatnot, it's become very difficult to use soft tissue procedures to achieve your goals. For ambulatory kids who have equina varus, this causes instability during that first prerequisite of walking in stance phase. And so, they often stop walking because of these deformities. In non-ambulators, on a cold winter day like today, here where I am in the Northeast United States, these kids are unable to wear things like typical shoes or boots that can keep their feet warm. And more importantly, for these teenagers, they care about their appearance just like any other teenager, and not being able to wear a nice shoe or a sneaker has an impact for them. But a lot of these kids, just like this kid here, you can see on the side, he's 18-year-old male. He's non-ambulatory for the past few years with Duchenne. He's doing okay, but his only problem is his foot is not fitting on his foot plate. And when it is on the foot plate, it causes him pain. So the goal of correction in these cases, even in non-ambulators, is to obtain that plantar grade foot and allow for good shoe wear. So here's this kid again preoperatively. You can see that equina varus. And so we did, in this case, I would do a tendo Achilles lengthening and a tibialis posterior transfer. He still had about 4+ out of 5 tib post strength. And we did a complete transfer through the interosseous membrane to the lateral cuneiform. And here's where he has foot post-op. He can fit his foot on his foot plate. He came in with a real fancy pair of shoes. I just saw him, took these pictures yesterday. He came into my neuromuscular clinic, and I said, hey, do you mind if I show a bunch of people, surgeons in India, of your foot? And he said, yes. He said, you changed my life, Dr. Howard. And, I don't hear it that much that people say that. But he said, I had to wear these big fluffy slippers, which made me look like a child. And also I was having pain. So none of that. Now I don't have any of those problems. So, you can make a difference in these kids' lives as well, even if they don't walk on their feet. So don't be too nihilistic about it. All right. That's a lot. Let's talk about CP a little bit, and particularly about hindfoot varus. We talked a bit about equinus, and that applies across the spectrum, whether it's CP or other neuromuscular conditions. But hindfoot varus or equina varus in CP is a little bit different. It's commonly associated with equinus, and the varus is driven during stance phase by the tibialis posterior, but during the swing phase is is augmented by the tibialis anterior, which really more supinates the forefoot and indirectly affects the hindfoot varus. You see an equinovarus foot position more in hemiplegics than you do diplegics. Diplegics, you might see it very early, but you have to be very careful because over time, the natural history of the equinovarus foot in diplegia is to progress to a planovalgus foot. So if you kind of do early lengthenings when a kid is 4 or something, when they have that equinus, you may make that planovalgus foot really bad when they are in sorry, but that was silence the phone. When they are in their early teens. So to be careful about making that natural history worse. They can appear rigid, but are often supple after soft tissue lengthenings for kids who have neuromuscular conditions like spinal muscular atrophy, for example. Those deformities can really feel rigid. You release the soft tissues and they're actually quite supple. There's a few questions there in the chat. I wonder if I'll stop for a minute and just gonna answer those if that's okay. So from Dr. Ghosh, do you routinely do a posterior tibialis transfer and equinus correction in all cases? And do you split the tendon and loop it around the second metatarsal in cases of muscular dystrophy? So no, I don't do a tibialis posterior transfer and equinus correction in all cases, but only if there is weakness of the dorsiflexors, which would call for it. And so if you're talking about that kid with Emery-Dreifuss muscular dystrophy, for example, I could release her, I could lengthen her calf muscle for her equinus, but she would still have a drop foot during swing. Recognizing she had 5 out of 5 strength in her tibialis posterior, I thought, well, this is a person who doesn't want to wear a foot drop brace for the rest of her life. So if I can augment her dorsiflexion with a complete tib post transfer, and I've got a strong enough tib post to do that, then I will offer that. But in CP, this is completely different. And their drop foot is usually not due to weakness of the tib ant, but more due to selective motor control. So I don't do a tib post transfer in CP that way. All right, I think, and one more from Dr. Agarwal. How do you decide between a tib and tib post transfer and varus feet? Well, I'm going to answer that in a minute. So hopefully I'll answer your question next couple of slides. Thanks for those questions. So what are our goals of treatment then? They're different by functional level, no matter, if you're for CP or if you have any other neuromuscular condition. So for ambulators, you want to restore those gait prerequisites. You want to relieve pain. You want to facilitate brace wear for those kids that need it. And you want to improve the cosmetic aspects of their foot, psychological aspects of being a teenager. Usually when you're doing extra-articular type surgery in ambulators, although in more rigid deformities, you often need osteotomies and fusion, though in the young kids who are flexible, you can do soft tissue procedures. In non-ambulators, we're working more on standing function, kids who can use a gait trainer for limited steps, which is important for independence as an adult. Also pain, facilitating brace wear. And as you saw, being able to put their feet on wheelchair foot plates and not have discomfort. Again, if they're young and flexible, soft tissue procedures are, is the principle to go by. And once you get more rigid, you need to think about fusions being more appropriate. In non-ambulators, we don't use a lot of extra-articular osteotomies, but we do more fusions because the risk of recurrence is so high when you don't correct through the joint. That would be a principle. You need to ascertain when you have hindfoot varus whether or not it's flexible. We talk about the Coleman block test, which typically used in kids with a cave of varus foot, like in Charcot-Marie Tooth, but it's also there in other in equinovarus as well. So you can get an idea about the flexibility by doing what I call the prone modified block test without the block. And you can see I've got the hindfoot is in varus there on that picture on the right, or say left side. And then I'm twisting the foot at the forefoot and seeing how that hindfoot goes into neutral or valgus And so that's the way I do this. I do it in the prone position, and rather than getting them to stand up for kids who sometimes have a lot of trouble just standing up for any amount of time at all. So this is a way to do it in kids with more profound weakness. And if that's rigid, then you want to think about more bony procedures. Here's a case, 9-year-old with spastic hemiplegia. So check out the right foot. That's the one that's the biggest issue. One thing I would say, you can see he's internally rotating there on that right foot. He's got forefoot supination. He's got some equinus, which is not too bad, the equinus, but there is some there. And he's got hindfoot varus. I apologize if it's hard to see. He's got normal tibial torsion, though, despite having that in-toeing that you see there on that right side. To identify where that supination of the forefoot's coming from, I try and assess whether or not they have poor selective motor control. And the confusion test can help you, where you ask the patient to push their knee, flex their hip, and push their knee against your hand. And then you can see, I don't know if you notice it there, but you can see the tibialis anterior firing and pulling that foot into dorsiflexion, but also supination. So that affects the prepositioning of the foot for initial contact. And you've got co-contraction of that tendon because of the poor selective control. I wouldn't say this is pathognomonic, but it can be very helpful, particularly if you don't have a Gait lab. Like I have a Gait lab. We look at EMG. So that's the best way to determine its abnormal function of tibialis anterior during swing. But if you don't have this can help you as well, this simple test. So here's the kid, the 9-year-old, hemiplegia on the right side. We did a Hoke TIL. Remember, hemis don't crouch, so I was okay to do that in this case. We did a split tibialis anterior transfer because he had a spastic foot, so I didn't want to do a complete one and risk overcorrection. We did a split tib end transfer to the dorsum. I transferred it to the peroneus longus to get a very high lever arm there. We also did a tibialis posterior recession. So the tibialis posterior affects the hindfoot varus during the stance phase of walking. So we did a fractional lengthening of the tib post. And now you can see how he looks now. So here, remember, it's the right side. That varus is gone. And come on back there, dude. And if you look at him from the front, remember that dynamic internal rotation that he had. He still has a little bit of in-toeing, but much better. And that forefoot supination is gone. And if you look at him from the side now, remember, it's the right side. Gets a good heel strike. It's his first rocker, second rocker. His third rocker is not so good. He doesn't have a lot of push-off. I lengthened his gastroc and his soleus together. It's going to take a while before that strength comes back. If ever, it's a big surgical hit. So, maybe I should have done this more in the calf than at the heel cord. I talked about the Frost. Frost is the name of the surgeon who first described this, of the tib post recession. You can see your starting point for your incision is 3 finger breadths above the tip of the medial malleolus. See the incision there? You do a strayer first to deal with your equinus. And then this is the deep fascia over the tibialis posterior. In fact, that's not the tibialis posterior that you see first. That's the flexor digitorum longus. You have to go deep to that. You find your tib post. You can see the tendon here is pretty big, but there's muscle also there, that lower right-hand corner. So we want to leave the muscle behind. And but before you cut anything, you want to confirm, is this tib post? So I do a little test on it. I kind of pull on it. You can see that ankle inverting. Okay, so now I'm happy that it is that. I just identify the tendon alone. I leave the muscle belly intact and release it. And then I do a split tib end tendon transfer. So I use a pointed towel clip to do this. That's my little trick. To split the tendon, you can push it through the tendon so you don't have to worry about amputating it. And we lengthen that, we split that all the way up to the extensor retinaculum. Then you need to make a tunnel across the foot. And then you release the lateral half of that tendon. That's the tibialis anterior. And then you transfer it to the other side of the foot. here we are at the lateral aspect. Here's this little oblique incision over the peroneus brevis. And there's the brevis. I also split that with my pointed towel clip. And I take a slip of the medial slip of that tendon and connect it to the split tibialis anterior. And there you can see it attached there on the side. And this is kind of like the reins on a horse now. So it pulls the foot up in a balanced way, both medially and laterally. So that's why I think it's better to transfer to the peroneus brevis than it is to go to, say, the lateral cuneiform or the cuboid. Okay, so that's a flexible foot. And like I said, flexible equinovarus you can treat with soft tissue alone. And so here's a kid with spastic hemiplegia. Again, he's also got Danny Walker syndrome. He's got pretty severe varus. And I think I was being a little bit over optimistic. I did feel that he was flexible. So I did the same treatment. I did a tendo Achilles lengthening. I did a split tibialis anterior tendon transfer and a frost tib post recession. And here's what I got. It's better, but it's still not that great. And he had residual varus there, as you can see, and on the right side, and still having some issues with discomfort. So, and his AFO wear was improved, but he still had a stiff varus. So in those cases where you have a stiff hindfoot varus, whether it be in CP or whether it be in Charcot-Marie Tooth or otherwise, the lateral calcaneal slide osteotomy can be quite helpful. It's a oblique incision just behind the peroneal tendons. It's the lateral aspect of the foot. See, this person has some claw toes. This is actually a cavavarus foot that I was working on. Subparietal dissection around the calcaneus here. There's really nothing in the way there. It's a safe approach. Need full thickness skin flaps. And I start with a saw, and then I complete the osteotomy with a osteotome. Got to make sure you get nice blunt homens all the way around the other side. Remember, there's neurovascular structures on the medial aspect, so you have to be a little careful here. And then you have to release the medial periosteum, which can also often hold up your slide. So you really got to release that to get that that bone to slide laterally. And I often take out a little wedge of bone as well to kind of help to bring that heel laterally. So I make sure that I don't run into trouble with recurrence. So you can see that about 1 centimeter to 1.5 centimeter slide here on that left picture, and hold it in place with a percutaneous screw. And you can see the shift there on the Harris view on that right-hand side, right lower picture. So younger children with hindfoot varus may progress to valgus, so you have to be careful about that. You certainly don't want to do these type of procedures in a young children with diplegia. You probably want to wait until they're at least 10 years of age to see if there's persistent varus, which needs treatment. In the meantime, you can help augment or help their function or delay the need for surgery using bracing or some physical therapy. So here's another kid, very severe equinovarus, GMFCS level 2 CP, progressive, painful, non-braceable, extremely stiff. Here's his Gait lab reports. He's got, at the foot, he's got a, minus 35 at the ankle with the knee extended. That's your soleus, minus 23 on the left. But the soleus is also tight. The gastroc is tight. So he's got both of these aspects there, and rigid equinus. So before you do anything, you need to look at the flexibility of the foot. So this is not him, but you can see in the operating room for this kid, he has some flexibility, but the hind foot was not flexible enough in our case to avoid a bony procedure. I'm just going to fly through these a little bit because we're getting on a bit, but this is just his gait tracings. Here you can see his pedoporography. There's a normal footprint there on the left. And you see this child has lateral overload at the toe, at the base, at the metatarsal head of the 5th metatarsal. And that's where his pain's coming from. and he has it on both sides. So we're trying to affect that. So here's these preoperative x-rays, severe talipes equina varus in addition to a varus hindfoot. Here's his walking. You know, he's managing, but you know, for how long? Here he is there. So in this case, he had rigidity of his hindfoot, his midfoot, and this necessitated a triple arthrodesis. So we did this through an all-lateral approach in this case, where you can see the subtalar joint, the ST, the calcaneal cuboid joint, and deep to that, you can see the, I'll show you in a minute, you see the talonavicular joint from here as well. So we've got these, we identify these joints, when we take out wedges according to what we need to do. So at the subtalar joint, you can see we're taking out a wedge with a base laterally. So I can bring that ankle, that hindfoot into valgus from its varus position and close it down. At the, here's the talonavicular joint. Again, this also needs to be, have a laterally based wedge. And in this case, I could expose it all through a lateral approach, but oftentimes you need to have a separate medial approach as well to really get that whole joint. Sometimes it's hard to get it. And so you can see I've taken out laterally based wedges at the TN and at the CC joint, and that corrects the talipes at the TN joint, but also the adductus at the midfoot. So everything gets corrected at the same time. And here he is. Now we use staples to hold it in place. You can see we augmented with some wires as well. And we let these kids fully weight bear on them so that they don't lose any time being off their feet. And this kid also had a brace after that. Is there anything in the chat there that anyone wants me to address? Sure, if I can see it there. Looks okay.
Yeah,
Darren?
I think already we have covered all the issues.
Yeah. I just have a couple little slides about spina bifida, and then we can open it up for questions. Is that okay?
Yeah.
Perfect. All right. So spina bifida is not talked about as much these days, or myelomeningocele, but it's still in our practices. We have a dedicated spina bifida clinic at DuPont, which has about 150, 200 kids in it, which doesn't seem like a lot, but they take up a lot of resources. Foot deformities are very common in spina bifida, but the goal for these kids is really a plantigrade foot, which is flexible and braceable, whether they're ambulatory or non-ambulatory. Just like we already saw, clubfoot actually occurs quite a lot in myelomeningocele, equinus. You can also get calcaneus and valgus. So, severe dorsiflexion contractures and valgus contractures. Congenital vertical talus is also there. To start off with, if you have clubfoot or vertical talus, Ponseti clubfoot casting has been described. And it does give you a good initial correction. I'd be very careful with your casting to not cause pressure sores and things like that. But there's a high recurrence rate, about 60%. So you need to be ready to do something else in the future and let your families know about that. Because they often will still need a posterior medial release in the future. And to be wary of using foot abduction orthosis, those FAOs you use in idiopathic clubfoot, because they can get a fracture at their distal tibia just above the orthosis itself. So we use a Staheli style cast brace or AFO instead. Now here's a newborn with myelomeningocele and really an atypical clubfoot, I would call that, with that plantar crease you can see there. So you need to use the modified Ponseti method for this. And just like you do in any Ponseti, you use sequential casting. And I've got 5 casts here, but you have to be ready to do somewhere between 6 to 8 more commonly, because these are more rigid deformities. And also, you need to be a little bit careful with the skin. So you don't want to put too much pressure on it at each casting. So be careful about that. This kid actually did pretty well. You can see initial cast was in very severe equinus, and then we got him up to, after a few casts, to needing a TAL, and then we did the percutaneous tendon Achilles lengthening and got him into a good position. Just like we do an idiopathic clubfoot, we kept that last cast on for 3 weeks, and then we got them into the cast braces. And that worked pretty well for this patient, and I didn't actually have to do any further surgery, which is probably the exception rather than the rule. So you have to be careful about this. This is very much a teratologic clubfoot. So try the Ponseti first. If it fails, tendon releases. And instead of doing tendon lengthenings, what we do in spina bifida is releasing the tendons completely. We're looking to have a foot that is more flexible and flail, that you could fit in a brace, that doesn't cause breakdown of the skin. If you have a very resistant clubfoot, sometimes you need to do a talectomy so you can keep the mobility of the foot, but address the part of the deformity, which is keeping it stiff. So here's a kid with, who had initial Ponseti and some soft tissue releases early on in life and had a recurrence. And to maintain her flexibility, but still correct the deformity, we had to take out the talus. And here she is postoperatively. You can see we used some just some Steinman pins to hold it in place, and with some casting. And she had a braceable foot after this. So there's still a role for talectomy in some cases. Calcaneus deformity is a tough deformity to treat. Often causes heels pressure sores. You get very significant contractures of the dorsiflexors and perineals, and you often need to release those. And again, your goal is a braceable foot. Whenever you're treating someone with spina bifida, you have to really think about, if you have a rapid recurrence of that clubfoot deformity, you need to be thinking, well, what's going on? Maybe I've got a tethering of the spinal cord that's happening here, and you might need to have a neurosurgeon involved to do a tether release. So for those cases, you really want to investigate, do I have a recurrence of a tethered cord? Something especially like a lipomeningocele or a prior tethered cord, probably more so than a true myelomeningocele, but it can happen there as well. So you do a detailed exam at every visit and address any interspinal issues as they come. Finally, I just want to make a plea to not just look at the foot, but look at the whole lower limb. If you have an external foot progression, that can be caused by abductor valgus or plantar valgus foot, but it can also be caused by an underlying external tibial torsion, or it could be both. And associated with that, you may often have internal femoral torsion as well, which gets unmasked after you fix the foot deformity. So, if you can get access to a gait lab when you're trying to treat these patients, or even if you can't, do a good physical examination, use your phone, get a good video, and scrutinize it before you just do foot surgery alone. So you may need to consider multi-level surgery in these cases. So, in summary, foot deformities affect your ankle rockers and your gait prerequisites. You need to keep those in mind. You need to treat your equinus, but beware of the dose, particularly in kids who have weakness. Your surgical dose is important to preserve that plantar flexion knee extension couple. And your goals are different depending on if you're ambulatory or non-ambulatory, as we spoke about. Split transfers for spastic disorders, complete for non-spastic. Your flexibility is important to determine whether or not you can do soft tissue procedures or extra-articular versus bony fusions. You can use Ponseti in spina bifida, but you have a high recurrence rate, and please address the whole limb. Think of the whole thing. And thank you very much. I'm sorry I went over. That's a lot to cover in one talk, but hopefully I was reasonably clear. Happy to answer any questions. Thanks. I'll stop sharing.
Can you stop screen sharing?
Yes, there we go.
Yes, yeah. Thank you, Jason, for a wonderful explanation and explaining the principle. To start the question, suppose we talk about 3 conditions. The one is diplegic, the second is hemiplegic cerebral palsy, and the third is Duchenne's muscular dystrophy. If we need to carry out a calf muscle lengthening, how much dorsiflexion you will try to achieve?
Oh, that's a good question. So again, it depends on what your goals are. If you're talking about a child who's ambulatory in diplegia, for example. They're going to be ambulatory. So in those cases, my goal is to first leave the soleus alone. So in diplegia, I almost never touch the soleus. So I never do Achilles tendon lengthening. That's number one. I'll always do, for equinus, a gastrocnemius recession, a strayer. And my goal is really to achieve dorsiflexion of no more than 5 degrees with the knee extended. Kurt Graham used to say, a little equinus is good for your soul. And what he was really saying was, don't mess up the plantar flexion knee extension couple, or you're going to be having to do distal femoral extension osteotomies down the road. And, we want to keep these kids walking for their lifetime. And the one way to do that is to really respect the soleus muscle. If you're talking about Duchenne muscular dystrophy, the fibrosis that occurs in the gastroc also occurs in the soleus. So you pretty well always have to address both. So I will always start with a Volpius type procedure. So work at the muscular tendinous junction of the calf posterior medially. I'll release the fascia of the gastroc and the soleus together. And my goal is really to get them to about -5 degrees. I don't want them to get anywhere near neutral or 5 degrees. In this case, keeping a little bit of equinus is important to get their heel closer to the ground, to give them better stability in stance, but not so close that that ground reaction force goes behind the knee. So the dose is very low in those cases. If the kid is non-ambulatory in Duchenne, for example, they usually have very severe equinus contractures, and you really can't get enough from just doing the calf Volpius. In those cases, you do an open tendo Achilles lengthening, and you don't have to worry about, losing that plantar flexion knee extension couple. You're trying to get their foot plantigrade for shoe wear and placement on the foot plates. So that's a high dose procedure. And I often almost always I augment that with a tib post transfer. And the reason for that is to prevent recurrence and to keep that position. And if you do both of those things, I've never had to go back and do it again. So it's a lasting surgery for those kids. Ambulatory kids with Duchenne, again, if they have the equinovarus positioning, the tib post transfer can also be very helpful in those cases. But again, I don't want them plantar flexing past -5 degrees when they're asleep. I want a little bit of equinus because your goal is to keep them walking. But you do have to be nuanced about what you tell the parents. I tell them there's a chance this won't work at all to keep you walking. But it'll be okay for the future with your wheelchair, or it might give you another year or two of walking. But that's it.
Okay, you missed about the hemiplegic, because hemiplegia and that again depends on the two age. Like first is like child is 5 or 6, and the second, the child is around 10 or 12. Okay.
In those cases, the first thing I think about is recurrence. So when you're looking at age, if you do a tendo Achilles lengthening or any calf lengthening in a child that's under age 6, you have to be very careful about it. If they're functioning really well, I just say, listen, he's got a tight calf, but he's running. She's running. Let's not upset the apple cart. We're going to have to deal with this at some point, but let's not do it now because there's about a 30% chance I'm going to have to do it again. And it's never as good the second time. So I usually try and push those kids off until they get at least over age 6 and ideally around age 8. And in those cases, I think it's dealer's choice. I think you could do, if you're comfortable with doing an open tendo Achilles lengthening, I think that's okay. I typically do a Volpius again. And if I don't get quite enough with that for more severe deformities, I'll do a little percutaneous hemisections like you do in a Hoke, just to I do one and then say, okay, I get a little more, do another one until you're just right. Like you're seasoning your soup. Once you get the right taste, then you stop. And so Dr. Schrader here with me calls that the Howard double dose. But I don't think it's double dosing. I think it's an intermediate dose between the calf lengthening and the open TAL. And the older kid will almost always need that, because but it depends on their extent of deformity. But you don't need to worry about crouch in the hemis.
Okay, no, my question was related to the recurrence rate. So, if we try to see, the first hemiplegics are not likely to go for crouch.
Right.
And the second thing is we know that if we do it at younger age, they are likely to go for recurrence. So in that case, why not to do it slightly more, like say 10 or 15-degree dorsiflexion, so that we can delay the recurrence or avoid the recurrence completely?
Well, I don't actually think you do avoid it, to be honest. In the young child under age 6, there's still so much growth to happen. The kid with hemiplegia already has a small muscle, but those muscles grow slowly while the bone growth grows normally. So you're bound to get a recurrence of the contracture just based on that in a lot of cases, not all cases. But the other thing to think about is that these are very highly functioning kids. I just saw a kid yesterday, for example, who is a varsity level lacrosse player, wrestler, and football player. And when I was going to do, he had an equinus, and we needed to deal with it because he was tripping. But I was very careful I didn't want to do a TAL because I knew that I was going to really weaken him. So I went further up in the calf and I did a Vulpius type procedure. I didn't overdo it with my dorsiflexion, and his strength came back quickly. That doesn't happen with your TAL. If you do a TAL in the younger kid, then maybe, I think probably it would come back mostly. But I don't believe by getting more dorsiflexion, you're going to reduce your recurrence rate. My goal is with the knee flexed 10 degrees of dorsiflexion and with the knee extended 5 degrees. That's what it is in hemis for me. And if you do that after age 6, that holds up pretty well. Yeah. It's philosophy though,
Okay. Then another important practical question, type 2 hemiplegic, when we carry out calf muscle lengthening, we convert them into type 1 hemiplegic. Means we have taken care of the calf muscles, but the dorsiflexor is still not functioning, not because of the weakness, but because of the selective motor control. So in that case, what are the strategies for going for tendon transfer? Do you do it or you don't do it and give lift spring AFO?
Yeah, just for clarification for the audience, what Dr. Gandwal is talking about is the Winter Gage Hicks classification of hemiplegia, right? Yeah. Where the type 1 is a drop foot without a contracture, and type 2 is a calf contracture with or without a drop foot. So yes, for those kids, I don't believe that a split tibialis posterior transfer to the dorsum that hasn't really borne out to keep that foot elevated. And I don't transfer it completely to the dorsum, the tibialis posterior, to augment the dorsiflexion for the reasons I talked about. Because you really, especially anybody has a little bit of underlying dystonia, which a lot of hemiplegics do have, you can really get a severe deformity. And we've had a few of those that have come through from other centers recently. It's really difficult to come back from that and treat it. So I will not what I do is I basically counsel the patients. I'll say, our Gait lab helps us with this. You have a drop foot as well during swing. So I'll treat your contracture, but the drop foot's not going away. So those kids, I often will give a carbon fiber type leaf spring, which is very low profile and actually gives them a little bit of a spring in their step. They can play sports in that and everything. Or I'll give them like a foot drop band, whereas it's like a little Velcro band that goes around their ankle, which either hooks into their shoe or has some straps that go around the foot, and that's helpful. So sometimes they'll keep that. Other times they'll just say, "Oh, it's too much trouble. I'll just swing my foot around. I don't mind." So yes, but I don't do tendon transfers for drop foot due to problems with selective motor control in spastic disorders. Meaning I don't do tendon transfer for dorsiflexion because I think it's risky. You might get away with it, but you might not.
Okay, and then the last question. We have already overshoot the time, but still the
Yes.
last question. Let's take a
There's a chat
hemiplegic.
too, Dr. Duran, as well. There's someone in the chat there as well.
Yeah, okay. So after this question, we will take the chat question also. So
Yep.
the question, let's take a hemiplegic. You already explained that they have a problem that the bones are growing, but muscles are not growing to the proportion of the increase in the bone length. What is the reason for that?
Yeah, we're learning a lot more about, muscle and cerebral palsy. That's actually, I'm also a basic science researcher. My area of interest is in spastic muscle. So what we're learning about it is that it's not just a brain problem in CP. There's also a primary muscle problem, probably related to DNA methylation, and the insult that happened at the time of brain injury also had impacted the DNA, way the cells are methylated in the muscle, because we're finding decreased satellite cells or muscle stem cells. We're finding upregulation of fibrotic progenitors. So collagen is elevated in CP versus typically developing controls. And because of the problems they have with this DNA methylation in satellite cells, the muscle can't regenerate or grow as fast because it's those satellite cells which make the myofibers. So if all these things are not happening that well, the muscle is growing, but just not fast enough to keep up with the bone growth. And so you get a mismatch. You get bone growing longer and the muscle tied to either end of the bone, which is just stretching and stretching and getting tighter and tighter. So that's what I think our basic science work over the past 5 to 10 years has really helped us to understand that it's more than just spasticity from the brain. It's even, it's intrinsic to the muscle as well.
Okay, and then the completely other end, some of the diplegics, they go for a crouch gait. And in India, we see a lot of patients who have not undergone any surgical treatment. But still they go for a crouch and they have excessive long soleus. So why that is happening? So on one side, we see a muscles not developing enough. And on the other end, the soleus is lengthening like over what is required. So what is the reason for that?
Yeah, I mean, that's very astute. It's easy to blame our surgery for everything.
No, but like we see a lot of diplegic crouch, who have not undergone any surgical treatment, but still they have a crouch. So we can't blame surgery all the time.
That's right, exactly. No, I completely agree with you. And, we're lucky we have a huge population of kids with CP here. So we looked at our I think it was a lot of kids, maybe 500 children with diplegic CP, and looked at the change in their sagittal gait pattern over their childhood. And we found, just as you said, early on, the rates of crouch were low in diplegia. There were some, but mostly low. And as they progressed to their childhood, though, as they hit 18 years of age, at 18 years of age, about 50% of kids with diplegia had some sort of crouch. And that was not impacted by that happened regardless if they had plantar flexor lengthening or not. So we concluded there that, crouch is part of the natural history of diplegia in many cases. And that just means you have to be even more careful about making that natural history even worse. In Melbourne, they do a lot of protection of the soleus by really never giving somebody with diplegia a hinged brace. They're always having a solid brace. I'm having trouble doing that with all my kids here because there's so many PTs out there who want them to be able to climb stairs and things like that. So, there's competing interests, but protecting the soleus, number one, from surgery, but maybe protecting it from itself, just from weight bearing by supporting it with a solid AFO would help. As to why that's happening, that is on my list of research ideas for the basic science side of things. My thoughts are that it's related to issues relating to the sarcomere, and tighten, which is another big discussion, but something we'll want to look at in the future. I think the muscle kind of loses its gas. You know what I mean? It just runs out of gas and can't maintain its tension or strength over time. So we need to be really sensitive to the soleus. The soleus is especially sensitive to that. Yeah.
Okay. Then we have two very good questions. The first question by Dr. Jitendra Jain. Is there any role of tibialis anterior tendon shortening in hemiplegics? You must be knowing that Professor Reinhard Brunner from Switzerland, he said that he used to carry out a shortening or the plication of tibialis anterior tendon. So what are your views on that?
Well, also here, Freeman Miller, Freeman has retired from clinical practice, but he's still here with us in the Gait lab and part of our research team. But Freeman was a big advocate of doing this tibialis anterior imbrication, even before Reinhardt and Eric Rutz had described it. And he would do it in the cases where there was a very severe equinus. So you knew that tibant was stretched out. And so he's had some success with it anecdotally. We've not looked at it in a research way yet. I know Dr. Schrader's done it a few times in those severe ones. I've done it a couple of times. I'm not convinced it helps. I think a lot of the issues relating to drop foot are based in selective motor control, and there's not much we can do about that. But it's something we need to study. For now, it's really just the Basel group that I've seen that's written on that. So probably we should look at our role, although we don't have a lot, so I'm not sure that we'll be able to come up with the answer. But I don't personally think about it too much. I haven't done one in 3 or 4 years.
Okay. Then there is a question, when there is a tibialis posterior overactivity, we have two options. The one is to carry out a fractional lengthening according to the Frost, or the second option is to split transfer the tib post. So which one is your preferred surgery?
I prefer the Frost. There's 2 reasons for that. The main reason is that there are a couple of studies that look at split tib post transfer versus the Frost kind of head to head, which is for spastic equine varus, which really show there's no difference between the two as far as how they affect the hindfoot. For me to do a split tib post transfer, it would probably take me half an hour, maybe 40 minutes. Probably not 40 minutes, but at least a half an hour. It takes a lot of fiddling. I usually have multiple surgeries to do. I'm doing the whole limb. So each half hour adds up. To do a Frost, it takes literally 5 minutes. Less than 5 minutes. I think I did it in 1 minute one time. So, it's about economy of surgery. If the split was truly better, I would do the split, but I don't believe it is. So that's why I don't do that. But I think it's whatever you feel most comfortable with. They're both equivalent. If you have the time in the OR, then do the split. But I would encourage you to have a look at the Frost. It's so simple.
And then there is another difficult question, which is like a lot of crouch patients have a over-lengthened calf muscle. So have you done a plication or implication of tibialis, the tendo-Achilles to maintain the length of or achieving the length of calf?
So trying, like we do, we shorten the patellar tendon, for example, when you're
exactly. So something like that.
And that seems to work, but it doesn't work. It's been done. It's been done 50 years ago or more. And as I've seen, papers about it over the years, but mostly I've been influenced by my teachers who tell me it's been tried, it doesn't work. The tendon stretches out again. And that may be related to the issues related with the soleus. And just once it's incompetent, there's no return from that. The difference when we do the distal femoral extension osteotomy is to be able to shorten the patellar tendon. you can't just shorten it. If you don't do a shortening of the bone, you won't be able to shorten that patellar tendon, or at least it won't last. It'll stretch out itself. So maybe one of the other missing pieces is we would have to shorten the tibia itself, which nobody's going to do that, right? So I don't know. I think
we need to lengthen the tibia for the overlength stuff.
Yeah, sure. Lengthen the tibia. Exactly. Yeah, it's the opposite. You're right. Yes, it's a lengthening thing. So yeah, maybe, but I think it's more related to the soleus. And if you lengthen the soleus fascia by 1 centimeter, you decrease its strength by 30%. So when we do a TAL, that's probably like 60 or 70%, equivalent. So yeah, so I think that's a problem. Whether you can do it in that patient you talked about who a natural history went into crouch, I'm not sure. I don't think I wouldn't want to do any lengthenings in the spastic CP population either. That's another issue, which can be a lot of trouble. But I'd love to find some way to do that would work, but that would just change our practice. So come up with something, everybody.
Yeah.
Know about it.
So thank you, Jascon, for a wonderful interaction and a beautiful lecture. And you really explained the principles of management. And once again, thank you on behalf of our fellows and the teachers who are very interested in this type of teaching. So I really, from bottom of my heart, would like to thank you for your kindness and your interest in sharing your knowledge. Thank you and have a great time.
I'm very happy to do it, and thank you for inviting me.
Yeah. And so next time we will be taking another very rarely discussed topic, that's muscular dystrophy.
There you go. I'll have to get on that right now.
Exactly. Thank you and have